Okay, we'll continue talking about the liver. The first video introduced basically the symptoms of liver disease by giving us an opportunity to review what the liver does. If the liver is failing to do its job, you'd expect each of its primary functions to be reduced. So let's dive in a little bit to the clinical pathology and first talk about things that might be done to test for liver disease. So the first of these is called liver function tests, frequently called liver function tests in an electronic medical record. That's a little bit of a misnomer because they're really measuring hepatocyte injury. So to say liver function test, it sounds like you're testing the function. These tests are actually looking for evidence of damage to liver cells or hepatocyte injury. So it's a very similar idea to cardiac enzyme testing. We're looking for things circulating in the blood that really shouldn't be there. So these are intracellular enzymes, enzymes that should normally live inside of a hepatocyte. So let's look at the first two, aspartate aminotransferase and alanine aminotransferase, AST and ALT. Now, I'll say right off the bat, you do not need to memorize the numbers for these. They will be provided if you are in a setting where you are looking at liver enzymes. You'd certainly be able to look up the normative values for that. Both of these enzymes are liver enzymes that are involved in metabolic reactions. So they're kind of involved in the hepatocytes doing their job, their normal kind of metabolism jobs. So if you see AST and ALT in the blood, these are signs of hepatocyte injury. ALP is a little different. ALP is actually a sign of biliary excretion function, so like the ability to secrete the bile. So the way that I remember this, because these enzymes are very similar, right? AST, ALT. Oh, I'm sorry. Oh, yeah. Oh, my gosh. I just reread my slide wrong. AST. I'm not sure if I said it wrong. AST, ALT. And the last one is ALP. It's got this P on the end. Do you remember we talked about in the last video that bile is kind of like the P of the liver? So the one that has the P at the end helps you remember that it's kind of like the P of the liver. And so ALP is actually giving you information of how well you can secrete bile. So when the biliary tree is obstructed, cells within the bile duct release ALP. So all three of these are liver enzymes, but the first two are specific for hepatocytes, and the last one gives you information on the liver's ability to excrete bile. These would kind of maybe be more appropriately called liver function tests, looking at some of the products that the liver alters or works with. So the first is bilirubin, which we had mentioned in the previous video. This is the final breakdown product of heme when we're breaking down red blood cells. And it's the liver's job to conjugate this bilirubin so it can be excreted in the feces. You can measure the amount of bilirubin in the blood, and if bilirubin is elevated, that can be evidence of liver disease. The clinical manifestation of this, kind of if you see in a chart review, elevated bilirubin, what do you expect that patient to look like? What are you expecting when you walk in the door? This should go hand in hand with jaundice, because jaundice is clinical evidence of elevated bilirubin. You get that yellowing of the skin and the sclera of your eyes. So albumin, you can measure how much albumin is in the blood, and the liver is responsible for the protein synthesis that creates albumin. So if the liver is having a disease, you would expect this to be reduced compared to normal. So reduced albumin in liver disease. What clinical manifestations should go hand in hand with low albumin? What do you expect this patient to look like if they have low albumin? Albumin is the primary determinant of plasma oncotic pressure. So if this is low, you're expecting fluid to be leaking out of capillaries. So maybe some ascites, some peripheral edema. This is a way of kind of bringing a chart review to life, right? This is a laboratory value that you can check in an electronic medical record, but when you see low albumin, this should hopefully beginning to give you a clinical picture of what they might look like, what you may be walking into. All right, prothrombin time. What do we expect with someone with liver disease? So the liver is the place where we make a number of our clotting factors. So if we are not making enough clotting factors, we would expect it to be difficult for us to make a blood clot. If it takes longer to make a blood clot, you're more likely to bleed. So in liver disease, you expect an elevated prothrombin time, or INR is another way of saying that. Again, what are you expecting from a patient with elevated prothrombin time? I kind of already gave the game away, I think, on this one. But these patients have a bleed risk, right? So you might expect some mild hematomas on their skin, more bruising than normal. And then obviously in terms of clinical decision making, the degree of their bleed risk will impact your willingness to do early mobility and get them moving if you don't deem them to be perfectly safe. So at the top of the next page of your notes, it talks about the mechanism of injury. And patients who experience liver disease can have both hepatocyte necrosis and hepatocyte apoptosis. So disease can cause reversible changes to hepatocytes. And then, if that stressor is severe enough, the cells can die by either necrosis or apoptosis. So on the left, we see hepatocyte necrosis. And classic to cells undergoing necrosis in the liver is they begin to accumulate fat and bilirubin. So you can see sections of necrosis that are kind of darkened. This type of cell death is most often linked to hypoxic injury and ischemia. So just like Unit 1, where we were talking about the steps of cell death that lead to necrosis, when hepatocytes experience ischemia and hypoxic injury, they can undergo necrosis. Apoptosis is also possible. It's more likely in response to toxin exposure or an autoimmune situation. But the single cell, the arrows are pointing to individual cells that are going through apoptosis. This little patch down here is some inflammatory infiltrate that has come into the liver, leading to damage and injury. So let's now talk about liver disease. I know we're kind of putting this on the back end, but hopefully we're kind of hold in our mind what the liver does, and then bring that forward as we learn about the different diseases. And we'll kind of a little bit take an aerial view on some of these because as PTs, we are not as instrumental in the treatment and management of patients with liver disease. It's important to know what these diseases are, how they present, for both when you're treating patients dealing with this disease, but then obviously being alert to signs and symptoms of an undiagnosed liver condition. But unlike the heart and the lungs, where we are straining that system and challenging that system to make it better or make it stronger, or, including that in our treatment approach is one of our goals. The effects of an organ disease like a liver is more just like, how is this going to be an impediment to my therapy? So I want to understand it, but we don't necessarily have to do as deep of a dive. So hepatitis is the liver inflammation, right? So whenever we see itis, it just tells you that you have an inflammation. So hepatitis, that's a repeat there. Hepatitis is can be used to describe both acute and chronic injury. So it can be both an acute inflammation or a chronic inflammation. Patients who are experiencing hepatitis can have a variety of origins. So there can be viral origins of hepatitis. And in The viral origins of hepatitis, which is what you see on the slide here, it's the name of the virus. It's given the name hepatitis because it has an affinity for the liver. So these are all just different viruses that happen to attack the liver, so we name them as such. Hepatitis A, hepatitis B, just different viruses that have a propensity to cause damage in the liver. There can be bacterial agents that get in and lead to an inflammation in the liver, as well as autoimmune attack, where your body has marked something within the liver as an invader and repeatedly attacks it. In general, hepatitis is usually considered asymptomatic. Patients may experience some fatigue and malaise, maybe a loss of appetite, occasional bouts of jaundice that can kind of come and go. But it's not super symptomatic when you first just have inflammation of the liver. If you do laboratory tests of someone who has hepatitis, sometimes you might see a mild increase in that ALP, showing that there's some effect on the biliary excretion. But in general, these are diagnosed kind of unrelated to the symptoms. The next category of liver disease is drug and toxin-induced injury. Since the liver is our major drug metabolizing and detoxing organ, it's extremely vulnerable to drug and toxin-induced injury. And we see injury from a wide array of chemicals. So many things can fall under this category. The most common drug-induced injury of the liver is acute liver failure secondary to acetaminophen, which is an underreported phenomenon. There was actually a really good This American Life. If any of you guys are NPR fans, it's getting a little bit old now, but they did a great section on acetaminophen toxicity and the prevalence of it. And you guys might talk about this in your pharm class, but the problem is that we're putting Tylenol into a lot of different things. So patients don't realize they're overdosing on it because they're taking Tylenol for pain, and they're taking a cold medicine, and then they're taking their prescribed painkiller that also has acetaminophen in it. And patients can very easily overdose with over-the-counter options, as well as prescribed. But the acetaminophen causes toxic metabolites that are produced and that ultimately damage the liver. So we have kind of a whole family of inflammatory diseases. We have the possibility of toxin-induced injury. And then we have kind of a big umbrella term of alcoholic liver. And alcoholic liver really includes a number of different diagnoses underneath it. And you can see kind of this schematic kind of shows the prevalence of these different types of liver disease in alcoholics. So we'll start with steatosis or fatty liver disease. So as it says in your notes, 90 to 100% of heavy drinkers will develop hepatic steatosis. That is in comparison to only about 8 to 20% will develop full-blown cirrhosis. So fatty liver disease in alcoholics is extremely common. And if you look at the mechanisms listed in your notes, you can see kind of why. The main mechanism and why it gets its name is that within the liver, there's an increased accumulation of intracellular lipids. So the hepatocytes get engorged in fat. The reason this is so associated with drinkers is that ethanol creates large amounts of NADH. And when you have a lot of NADH, it's going to take substrate away from breakdown or catabolism and move them towards lipid synthesis. So ethanol stimulates NADH, which takes substrates that would have been used in breakdown in the liver and redirects them to use them to make new fat. Ethanol also impairs the assembly and secretion of lipoproteins, kind of in the same mechanism, the fats that might have been gone into the production of lipoproteins are being pumped into lipid biosynthesis and stored within the cells of the liver. Now, this phenomenon of this increased intracellular fat can occur after just weeks or months of alcohol abuse. So this will occur very quickly because it's kind of a direct effect of the ethanol. So what does this look like? It can present itself as malaise, kind of that general feeling of being unwell, lack of eating and weight loss, upper abdominal discomfort, or it is related to the liver involvement, tender hepatomegaly, enlargement of the liver that's uncomfortable, and they can have a fever. Now, this list of symptoms that I just read off the slide for you can occur after, like it can be brought on acutely after a bout of particularly heavy drinking. So if somebody is an alcoholic, they might have, the underlying fatty liver, and then they have they have a night of extremely heavy drinking, and it will acutely raise all of these symptoms. In fact, each bout of heavy drinking in patients who have fatty liver disease carries about a 10 to 20% risk of death. So this is extremely common, and then the bouts of heavy drinking can lead to acute death, I guess is the easiest way to say that. So at the time that a patient has hepatic steatosis, you might see laboratory evidence of it. So they can have hyper bilirubin in the blood, bilirubinemia, elevated ALP. So ALP can go up, remember, with just an obstruction to the biliary tree, not necessarily cell death. So sometimes you can see AST and ALT elevated as well, but it's not necessarily cell death at this point. It's just that it's taking up the space and obstructing the tree. Leukocytosis is elevated white blood cells, and that is really secondary to the acute injury and inflammation going on in the liver. So the body is recognizing this injury is happening. So that's fatty liver, by far the most common. About 10 to 35% of heavy drinkers will develop alcoholic hepatitis. So this is under that larger umbrella of inflammatory liver disease. The mechanism is really unknown as to why patients develop the inflamed liver. The theory is that it's toxic injury from some of the byproducts of ethanol and its metabolites. So the overwhelming load that you're putting on the liver to break down the ethanol actually causes a toxicity in the liver. And then about 8 to 20% will go on to develop cirrhosis. The timeline on this to get to cirrhosis is typically after more than 10 years of heavy drinking. So this takes a while. So where steatosis can occur very, very quickly, cirrhosis is actually in the fibrosis family, and this takes years and years of kind of damage to the liver to lead to the state where you're starting to get fibrotic changes. So we're going to circle back to cirrhosis at the end, but I just want to touch on non-alcoholic fatty liver disease first. So non-alcoholic fatty liver disease is actually the same disease as hepatic steatosis. It's just not caused from alcohol. So it's fatty liver in a non-drinker. This is sometimes referred to as NASH. You might see this written either way, which is just non-alcoholic I'll just write it out. My words seem to be failing me. It's the end of a long day. Non-alcoholic steatohepatitis. So it has the same name. That's NASH. These are really one and the same. Kind of depends on the person and their training for what they'd call it. So the reason this is becoming so much more prevalent is that it is associated with type 2 diabetes and obesity, especially central obesity. So these two guys kind of come together, And when you have these disorders, you have increased mobilization of free fatty acid. So there's more free fatty acid in the circulation. And the obesity, as it says in your notes, is especially central obesity, because when you have central obesity and you're breaking down the fat in your abdomen, they go into the circulation, and the whole portal circulation is delivered to the liver. So the first place that fat shows up is in the liver, and it's taken up by hepatocytes, and you end up with non-alcoholic fatty liver disease. So it looks and presents very similar. It's just not caused by alcohol. So part of the reason I presented the liver disease the way it in this class this way is because really outside of the mechanism of injury, a lot of these diseases look very similar. They impede liver function, and they're very interrelated to each other. So a normal liver can develop fatty liver disease with alcohol exposure. The person gives up drinking, they abstain from alcohol, and their liver can return completely to normal. Similarly, someone could have some exposure to a virus or a bacteria that causes damage of inflammation. The exposure goes away. They somehow reverse that, and it can get completely healed. And a lot of times there's cycles of this. Cycles of exposure and then return to normal. Cycles of exposure, return to normal. There is a threshold that can be reached with the steatosis, where after a certain point, it will progress to that hepatitis, or sometimes we'll just go directly to cirrhosis. The hepatitis, repeated attacks over and over, bouts of inflammation will ultimately lead to fibrotic changes. We could add to this picture the toxin and drug-induced injury can also lead to cirrhosis. So cirrhosis is just going to be the fibrotic changes that happen after repeated bouts of injury. So you can see that kind of all diseases ultimately funnel down to this end stage liver disease. So let's talk about cirrhosis. This is a picture here of a cirrhotic liver. If you note, the surface of the liver has all of these little bulging nodules. That's very classic of cirrhosis. We'll talk about that. It's the 12th leading cause of death in the U.S. And the main mechanism of cirrhosis is this progressive loss of normal tissue. And the normal tissue is replaced with fibrotic tissue and then what's called nodular regeneration. The reason that the fibrosis begins to happen is because of the repeated bouts of injury or exposure, repeated rounds of inflammation. The liver is very good at regenerating, which is why in the previous slide, you can have pretty severe injury and still get back to normal if you can get the offending agent out. But what happens over time is that as the liver tries to regenerate, which it's good at the same time they're developing scar tissue and the fibrotic changes, and the scar tissue actually kind of ties off the new growing liver tissue. So if this is like the surface of the liver, it starts to try to regrow and the scarring kind of bands around it, and you end up getting kind of pinched off liver tissue. So you get constrictive bands of scar tissue that tie off pieces of the liver. And this is happening throughout the liver, right? Restrictive bands of scar tissue wrapping around cells that are trying to grow, which you can see in your notes is kind of plays into some of the earlier symptoms that we talked about, like portal hypertension. If you're trying to get blood flow to go through an organ that is repeatedly kind of binding with restrictive bands of scar tissue, you can obstruct the blood flow through areas of the liver. If blood can't get through, we're going to increase the pressure behind it, and the pressure behind it is the portal circulation. You can get biliary obstruction. That's why you're not making bile as well as you should, or being able to excrete it, which is going to impact your ability to get rid of bilirubin, might represent itself as elevated ALP in your lab values, kind of evidence of that biliary excretion obstruction. So the liver is incredibly resilient. We have like way more liver than we ever could need, in a healthy situation. So many patients remain asymptomatic until the most advanced stages of this disease. So that's problematic in terms of diagnosis. The other reason it takes so long is because the early clinical signs, or I shouldn't even say early, the clinical signs can be very non-specific. Anorexia, weight loss, weakness. It's not easy for a patient to tell that something is going wrong, especially if you're not living the most healthy lifestyle. These might not be as obvious as they would be to someone who is living a very healthy, active lifestyle. If they are in the medical community and getting tests done, there would be clinical evidence of liver dysfunction. So the liver function tests, evidence of liver enzymes. There would be ways to diagnose this. It's just difficult for the patient to have the subjective signs in cirrhosis. So this is just a summary slide. It's basically a summary slide of the entire last video. So this is the clinical evidence that can appear of liver dysfunction, and each of these is tied to the primary functions of the liver. So portal hypertension is probably the one that's not. I should have led with that one. So portal hypertension obviously is related to the blood flow through the liver, and if it's blocked, you get pressure backed up. So clinical evidence of portal hypertension would be those esophageal varices. Can be esophageal or gastric. You'd see ascites here, that fluid that accumulates in the abdomen. This can cause nausea and vomiting because of the pressure around the stomach. We can see splenomegaly because of the congestion within the spleen. Then if you go down, there's really kind of two main functions, the synthesis and storage functions and the metabolic and excretory functions. So we know it plays a really huge role in glucose by making new glucose through gluconeogenesis or storing glucose as glycogen. So that's those fasting hypoglycemic events. Liver is important for protein synthesis. So when patients are having cirrhosis, you can see hypoalbuminemia presented as edema and ascites. If it's not making clotting factors, these patients might have evidence of bleeding. They get worse at lipoprotein formation. That actually is related to kind of how the fatty liver disease is formed, but you might actually see lower than normal cholesterol. The ability to make bile can be impaired, so they get impaired fat absorption. So that means that they're going to be have deficits in fat-soluble vitamins. You can also see evidence of fatty stools. When you go to the metabolic and excretory functions, we know that the liver plays this important role in converting ammonia to urea. Ammonia, again, is toxic to the cells. So when the liver is failing to do this, hepatic encephalopathy is extremely common in cirrhosis. We have those steroid hormones being metabolized, increased aldosterone. It's going to contribute to that edema and ascites. Because we can't metabolize the aldosterone, we have higher than normal amounts of that hormone, which means that we have sodium and water retention, evidence of increased estrogen. We didn't talk about this one actually in the last video, but they get worse at metabolizing drugs. So they can start to have drug interactions, and normal dosing of drugs can cause toxicities because they're not having kind of that first pass metabolism. And then finally, that breakdown of heme is impaired because you can't conjugate the bilirubin, which can give evidence of jaundice and pruritus. So I just kind of went through that real quickly because hopefully that felt very reviewy from the previous video. Once 80 to 90% of the functional capacity of the liver is lost in cirrhosis, the patient is in hepatic failure. And again, when the body lays down scar tissue, it doesn't go away. And cirrhosis is a disease of fibrotic changes of the liver. So this is non-reversible. There's no treatment that can get it back. So at this point, the patient would need a liver transplant to be able to continue to live. This is one of the easier transplants to get because of the donor availability. If you are interested in organ transplant, we will have a whole lecture in cardiopulmonary your final year where we really talk about the full scope of transplant. PTs play a really critical role, especially in heart and lung transplant. And in that talk, we talk a little bit about kidney and liver transplant as well. But because we can take a piece of an organ from a living donor, this bypasses one of the biggest impediments to organ transplant, and that's donor availability. So as PTs, I mentioned at the beginning of this video, this is a little zoomed out, compared to the, really specific details we went in the pulmonary lecture, for example. But that is because this is a disease that the patient might be dealing with and experiencing, and you'll have to account for, but our therapy doesn't really change it. So our PT implications are to be on the watch and to look for signs of undiagnosed liver disease, untreated jaundice, and refer them on. Once the liver is compromised, this is one of the few places that active intense exercise is actually avoided. Almost across the board, we talk about how exercise can benefit X, Y, or Z, but here really medical treatment is indicating the patient should have rest at this time because the body can't handle a lot more stress. It's important to know that they have increased risk of coagulopathy, reduced clotting ability. So if you are treating patients, being very cautious because they're really easy to bruise. So even some traditional soft tissue mobilization techniques might be too aggressive. Obviously doing extreme care with mobility if they are confused or not following commands, because with the risk of bleeding, you're always very worried that the patient could fall. The other thing to be aware of, and you guys will talk about this again in differential diagnosis, is that the liver can refer pain to the musculoskeletal system. So never stop trusting your own instincts. If something is of musculoskeletal origin, during your initial evaluation, you should be able to recreate that pain. By stretching it, by contracting it, by pulling on it, you should be able to recreate the pain. So these are just some of the common referral patterns for the liver, and you can see how they could be well hidden, like, right intrascapular, subscapular pain. It's not an easy area to get at. So if you can't induce it in the evaluation, that should be kind of a red flag. If you're starting a bout of therapy and your treatment is making no difference whatsoever, even not making it worse, like sometimes in PT, the first day or two, I always, you would warn your patients, like, it's okay to get a little worse before you get better, just so they come back to you. If you're not making it better or worse, trust your gut and refer them on, because these can really mask themselves as musculoskeletal issues, and there's no reason to treat it if there's no musculoskeletal injury. Alcohol withdrawal symptom is an important thing to be aware of, especially for the acute care therapists, because when alcoholics get admitted to the hospital, they lose the exposure to alcohol, and that can induce alcohol withdrawal syndrome. So the timeline of this is really important because this is when you're going to be seeing them in the hospital. So about 8 hours after their last drink, they likely start the symptoms they may experience are anxiety, insomnia, nausea, and some abdominal pain. Once you get to that 24 to 72 hours, patients can have high blood pressure, elevated body temperatures, arrhythmias to their heart rate. They can become very agitated and confused, might be having nausea and vomiting. If they are not getting any treatment for alcohol withdrawal symptoms, it can progress to full-on hallucinations, fever, seizures, and agitation. So when you're seeing someone in a hospital and they either have symptoms that very much look like alcohol abuse, or most 99% of the time it's documented in their chart that they have a history of this abuse. It's important to know when their last drink was. It would normally be found in the nursing notes, but if it's not in the chart, you want to ask the nurse when was their last drink. And the reason I mention that is that if you're about to see this patient and they're like day 2 in their withdrawal timeline, it might make sense just to wait a day, because they might be a much more calm, responsive person. And depending on what their needs are, if one day doesn't drastically impact their ability to be successful in PT and get home and reach their goals, they might be much more able to handle therapy and respond to therapy and be safe in therapy. So there is, in the world of liver disease, and I'm laughing a little bit because Katie Kester is my lab instructor in cardiopulm, and she's in the medical ICU. So almost all of her patients have hepatic encephalopathy. And so she would probably cringe when I would talk about not treating patients because they're confused. She's always like, oh, my patients are confused. But liver patients with encephalopathy are going to be confused today and tomorrow and the next day. So there's no reason not to treat that patient. You just have to, treat them within the bounds of where you feel safe and you think the patient is safe. But a patient going through withdrawal and they're just not having a good day and they're agitated and they're confused and, their EKG is showing all kinds of weird rhythm, and tomorrow they're going to be better. It's just worth the wait, because you will get so much more out of that therapy session when they're doing better and not dealing with these symptoms. So taking into account where they are in this timeline can be very helpful. So let's just end with what age does to our liver. And that will be the wrap on this one. So we'll start with the anatomy and then we'll talk about what it means for the physiology. So as we age, we lose hepatic cells. That's not all bad because we have a huge reserve of our liver. We have more than we need. But that does overall get smaller. It does reduce its regenerative capacity, which means it's less likely to tolerate injury and insult. We do see reduced blood flow to the liver and reduced hepatic enzymes. And you guys might have talked about or will talk about some of this with prescribing medications to older individuals can get really tricky, because as they get older and the liver function changes, dosing can be very different than in a young healthy, which gets us to our physiological changes to the liver. Because of the fewer cells and the fewer enzymes, we see impaired drug clearance, as well as reduced metabolic and detoxification ability. This also impairs our immune system, right? We have those resident Kupffer cells, resident macrophages, that when the blood goes through the sinusoids of the liver, it has to come in contact with macrophages, which are just ready to attack and phagocytize anything that's not really good for us or supposed to be there. As our liver gets a little worse at doing its job, so does our immune protection. So I hope that you came along on the journey with me and that you feel compelled to keep your liver as healthy and as happy as humanly possible. Have a great day.